Well, I'm talking from the 2017 CESCO annual meeting in Chicago about a topic that I really enjoy to talk about because I feel that's very important, that the management of diffuse large B-cell lymphoma in the elderly, which is really major topic and a model for oncology, I think. Well, indeed, it was focused on the diffuse large B-cell lymphoma, which is one of the most frequent lymphomas, which is one lymphoma that we can cure with a treatment which is not too aggressive, but aggressive enough to kill frail elderly. So the problem we have is to identify these patients with frailties, just to foresee whether we will have problem with the medications. So we have two ways to discuss it, and this is how the session was organized. The first point is to work on the geriatric assessment, the way to identify patient fit and patient unfit, which is something very much important from the beginning, but already difficult because there is not two categories of patients. There is a continuum from fit and unfit patients. But still, we have to be pragmatic and define some barriers just to begin with. For this, we have different steps. The first step is the identification of the group with simple tests. Well, we have something, but it's complicated. That's comprehensive geriatric assessment that use 7 tools that will analyze various impairments of the elderly, independence, nutrition, mood, cognition, and so on. That's feasible, but it takes about an hour or even more to make an appropriate evaluation. That led us to develop screening tools. So we have to work with, and there are various screening tools. There is the one I prefer because that's the one I developed, is named G8, but there are others that are quite good too. So first step is that. The second step, when the screening tool does identify some frailty, that's geriatric assessment. Currently, the problem we have is that it's long to perform, so we have to work on some abbreviated geriatric assessments. That's a way of research. And the third part of it is, well, once we have diagnosed frailty, what to do with it? We may work on it and we may correct, improve these impairments for the patients to better fit with the treatment. So that's the three. The first one, selection of patients with a screening tool, what's done? We have the data. The second one, geriatric assessment, well, we have demonstrated that it adds some prediction of the prognosis, a prediction of the different problems we may encounter, but it's still too long, so we have to work on that. The third one, it's demonstrated in geriatry, in the general population. It's not demonstrated in oncology, and in oncology we have a disease, a kind of comorbidity with some survival consequences that is too much important to consider that the geriatric intervention is useful. We have to demonstrate it, so there are trials to develop. So there's this part, which is important, quite well studied, but which is a problem, I think, to integrate in the hematological management of a patient. The hematologists have many patients to deal with, they don't have a lot of time, so we have to deal with that and to think ways to do it. Still, although it's, I think, not perfect, well, not well in diffuse large B-cell lymphoma, some hematological disease have made the job. In CLL, for example, in myeloma, they are already device systems. They are not perfect. They are, I would say, quite imperfect. But they are something to begin with. And I think, well, probably for lymphomas, I would propose something else. But, well, they do something. And I think for lymphomas, we have to devise something that may be the same that myeloma or different. Doesn't matter, but we have to do something. The second part of the discussion was about the specific management of large B-cell lymphoma and the different questions we have. The problem is toxicity. We have chemo, we have many usual febrile neutropenia and so on, and we are talking about risks. Indeed, the classical way of thinking was just on the intuition to design whether we propose anthracycline or not in this frail patient that we feel frail at least. And what is demonstrated is that with CGA, the appreciation of frailty is much better. And the second part that is not totally demonstrated, but I'm now very much convinced from data of trials or population-based study, is that doxorubicin should be pushed as much as we can, even in frail patients, possibly at low doses, but it should be pushed because it's so major that even if we have to face toxicity for the frail patient, there will be a benefit at the end. But it's only possible if the geriatrician is quite close, because we have to intervene, we have to do something during hospitalization, and our hematology wards are not ready to deal with this kind of patient because we need physiotherapists, for example, which is very important, and an experience to deal with depression and so on that is not, well, what we deal for young patients, for example. I think that's very important, first thing. Second thing, we need data for targeted therapies. Well, usually targeted therapy are supposed to be more efficient and less toxic. Most of the time that's right. But in the elderly, we face some toxicities that were not used with younger patients, which including, for example, decompensation of severe comorbidities like diabetes and so on. Well, we know how to deal with this thing, but it's slightly different in the elderly. So there are some specificities we have to work on. And especially with targeted therapy, which propose some new, I'm thinking, for example, of immunotherapy. That's what would be logical to propose them. But there are some complications of around autoimmunity that may last long, and in the elderly, the deal may be quite bad at the end. So what we need here is to collect data, which means that we have to think about expansion studies of phase 1, 2, and 3 trials for this specific population. We have to think about it. That's quite difficult because the pharmaceutical companies don't want to deal with too many toxicities. But if at the end it's when the medication is registered that they face this kind of toxicity, we already have observed what the consequence can be on the medication. So I think they have to do, probably not in the same trial, probably on separate trial, but they have to work on that, I think. Even if at the end is to say that, well, don't treat the frail patients with this medication because of that and that, or use some specific precautions.